Early. This is not the first session, the first time we do this session. Everyone knows everyone here on stage. The idea behind this panel is to provide you with the latest clinical updates for mostly scientific updates, but also clinical trials related to kidney cancer. So assembled the folks that did it, the folks that did this trial, the folks that discussed this trial at the last ASCO and ESMO meeting, as well as other meetings. So we're gonna start first by Dr. Brian Rini from Vanderbilt University Medical Centers, giving us updates about first-line trial and putting them in context.
Thanks. Thanks, Tony. Thanks to Tony, Hans, Monty, Brian, Susan, everyone for the invitation to this great meeting. Thanks for waking up early. So I was asked to talk about frontline kidney cancer, which I think everybody, a lot of data that people in this room know. So I'll just sort of try to give a high level. I'll talk a little bit about Cosmic as well, which is obviously the most recent relevant frontline data. So as everyone's aware, there's 4 trials that have extended survival in kidney cancer. We collectively call them IO-based doublets, either Ipi-Nivo or one of the 3 IO-TKI regimens. This is a table that you've seen many times, and I'm not going to go over the numbers, of course, but I'm just going to give you sort of my sense of the take-home themes from the data. So there's a remarkably consistent overall survival effect from these regimens, right? Sunitinib was the common comparator control in all these trials. They were broadly similar in terms of frontline clear cell kidney cancer and numbers and makeup and all that, broadly similar trials. And despite differences in drugs and differences in mechanism, the hazard ratio is 0.7 across, so very consistent overall survival benefit versus TKI monotherapy. I think the one other theme that emerges is that when you have a TKI in your regimen, you get more tumor shrinkage, right? So you get higher response rates, you get longer progression-free survival, and you also get less early progressive disease. So there's better disease control, if you will, with these TKI-based regimens. That may or may not be an important individual patient. We can talk about the merits of doing that and sort of the upside of tumor shrinkage and the downside of toxicity and potentially chronic toxicity. But I think that's a general theme. And I think most people would agree for that very bulky symptomatic patient that an IO-TKI regimen is probably preferred early on. And then a point that's maybe a little more debatable is about the role of Ctla4. I think it sort of waxed and waned over the years. I think Ctla4 early on probably does provide a higher tail of the curve. We don't yet have tails of the curve for the IO-TKI regimens. We just don't have enough follow-up. But we've seen the 5-year and soon 6-year data from Ipi-Nivo, and it's pretty clear that there's a subset of patients that's exquisitely immune responsive that'll have disease control now, again, 5-6 years out. And I think we're redefining the role of ipilimumab. We have the 8x8 study of Nivo versus Ipi-Nivo that will be out soon, which I think will help do that, but is only sort of part of the story. So that's an evolving story. Sorry for all the busy tables. This is just favorable risk, right? And I've included also in here, the 2 last columns are HCRN study, which Mike Atkins and colleagues just published in JCO, and then the KEYNOTE-427 study. And again, I'm just going to sort of go over themes. So there's really inconsistent effects on overall survival. Now, remembering these are small subsets, so take all this with a grain of salt. You can see the numbers across the top, 100 patients, and for the monotherapy, 30 or 40 patients, so very small numbers. But those hazard ratios aren't in the nice 0.7 range. They're sort of circling around 1, and we can certainly discuss that. You still get enhanced tumor shrinkage endpoints. And again, favorable risk biologically is more angiogenic driven. I'll show you a slide later. And so it's not surprisingly that the response rates and the PFS are higher in that group, in part because of the angiogenic biology, in part because, of course, they have a more favorable natural history. But there's a subset of favorable risk that's immune responsive clearly, right? So if you look at some of the immune-based data for Ipi-Nivo, you see a CR rate of 13%. So clearly, a lot of times people say, well, favorable risk is all angiogenic driven. That's clearly not the case, right? There's a subset, whether it's 13% or 20%, I don't know the percentage, but there's a significant minority of patients with favorable risk kidney cancer as defined by IMDC who are immune responsive. And the monotherapy data, frankly, is all over the map. And that may just be that it's 30 versus 40 patients, trials done in different settings, just the vagaries of clinical trials. But when I look at those 2 columns, I don't see a lot of consistency. I see a lot of inconsistency. So how do we choose treatment? Well, we could talk all day about that and debate, and we have over the last several years. These are some data that were presented at GU ASCO. Nazar's been involved. I saw Nazar in the room. There's a manuscript submitted to JITC, and really sarcomatoid histology emerges as a great biomarker to give Ipi/Nivo. So you see overall survival on the left, progression-free survival on the right, and you could drive a truck through those curves, in part because TKI monotherapy is so poor in patients with sarcomatoid kidney cancer, but also in large part because Ipi/Nivo does so well in those groups. And I've just pasted the response rate of 61%, a 23% CR rate in those patients with sarcomatoid histology, and these were all centrally reviewed. So this isn't just a checkbox on a CRF by a local pathologist. This is Sabina Ciretti and colleagues reviewing the presence of sarcomatoid. So in my clinic, that's where I use Ipi/Nivo, is for patients who have sarcomatoid histology. So these are data from the Cancer Cell publication from a year or so ago now. And I love this slide because it shows the 7 biologic clusters as defined by the Emotion 151 RNA-seq data. And it shows both the MSKCC and IMDC clinical risk. And I like it because it shows how heterogeneous those groups are. To my point earlier about favorable risk having all different biologies in it, each clinically defined risk group is made up of a lot of different biologies. And I think we probably recognize this clinically when we see patients. There's more angiogenesis on the left side of those paired bars, right, on the favorable risk. As patients accumulate risk factors, I think they accumulate more inflammatory biology, more myeloid-driven biology, and probably other biologies that we don't yet understand. But it's not nice and clean. And I think as we stand here at this meeting in years to come, I hope that we're not talking about IMDC, we're talking about biologic classification. I think we're probably going to do patients a better service by doing that. This is our OPTIC study, which is based on it. I think Scott or others, or Katie talked about it yesterday. So we're trying to basically take those clusters and prospectively validate that selecting patients based on clusters is better than just empirically giving therapy. This trial is DoD funded. It's taken us about 18 months to get up and running. We're actually finally up and running and starting to accrue patients. So hopefully in a year or so, we'll have some data to support. It's not perfect. I think Anupama talked yesterday. The informatics around defining clusters is not straightforward. I've learned a lot about that in the last year and a half. Again, they're not nice discrete buckets. There's definitely overlap. There's probably overlap in a given patient's biology, right? They're not just driven by one biology, one cluster. There's probably multiple. So this is just a start. I think if we can pull this off, we can use it as a platform to then test other drugs or even other biomarkers. And then the other thing I'll say about the IO-TKI regimens is that one of the questions that's not been well defined is duration of TKI therapy. There's some data about the duration of immune therapy, right? In the Pembro program, Pembro was stopped at 2 years. From 426, we're starting to get some data from those patients who stopped therapy. Presumably from Len-Pembro, there'll be similar data. So while not perfect, I think we're starting to get a sense of how long immune therapy needs to be continued. I think many of us feel it doesn't need to be continued forever. I think that's probably a general consensus. But for TKI, I think the dogma was that you do need to continue it forever. I don't really think that's the case. My personal opinion, based entirely on anecdote, is that it's probably the first 4 to 6 months of getting disease control that's important, and then I think it becomes less important. There are studies like this ongoing, and I know there's other studies looking at limiting the duration of TKI. And so I think we as a field, as we sort of forge ahead from doublets to triplets and beyond, also need to do what other fields have done and think about de-intensification of therapy, and not just intensifying and intensifying over time. So this was so I'm not going to move now to talk about triplets. No talk is complete without a Twitter poll. So this is actually a poll that came out. I was giving a talk on doublets versus triplets. This is before the Cosmic data came out. And I was just sort of taking the temperature of what people thought. And I put out there, what would be the most convincing endpoint to adopt triplets? You see 75% chose an OS benefit. The other ones I put in as a high bar, so a 12-month PFS increase, not a 12-month PFS, but an increase, a doubling of the CR rate, so really high tumor shrinkage or other endpoints. And you can only choose one in the poll, but most people in this poll anyway thought that that OS was the required bar to do that. If there wasn't an OS benefit, I asked a different question about, okay, well, how much PFS benefit? And as this poll sort of relates to the last one, if 12 months wasn't good enough, these lower time points weren't good enough either. So I think at least pre-Cosmic, and I think post as well, and we can certainly discuss, there's a sense that we need to be pushing the OS endpoint to adopt triplets, which of course are going to have more toxicity. So let me just go briefly, and what I think is the most relevant data that's been presented, and Tony presented this at ESMO for triplets. So again, IO-based doublets are the standard of care. I didn't talk much about monotherapy. I don't use much monotherapy in practice. We can talk about it. And again, I think the field's moving towards triplets. So this was Cosmic, basically Ipi-Nivo Cabo versus Ipi-Nivo in an intermediate and poor risk frontline clear cell population. This is the primary ITT population, the first 550 patients who were randomized. You see the PFS difference, about an 8% absolute difference at that 12-month mark, hazard ratio 0.73. So perhaps not surprisingly, when you, again, as we said before, when you add a TKI up front, you're adding tumor shrinkage, right? You're adding disease control. So I think a PFS benefit, it's good to see. And I think that's what I would have expected in this setting, is that you would get enhanced PFS from adding a TKI to Ipi-Nivo. This is the breakdown by the two different IMDC risk groups, and at the danger of overinterpreting small subsets. I was surprised at these data. I thought the poor risk patients would do the best. I thought they'd have the most benefit. If we think about an aggressive triplet, we think, well, we probably need to apply it to our sickest patients, i.e. the poorest risk. And again, relatively small numbers, but there doesn't appear to be a benefit in that subgroup. Those curves are interestingly crossing. So I think probably a lot more work to do to understand what the signal is there and who are those patients. Poor risk is a big bucket, right? It's 3 to 6 risk factors. So it's a big bucket of patients, probably driven by all sorts of different biologies that we don't understand and haven't well defined. To me, probably one of the take-homes from this trial was drug delivery. And I think as a field, we need to think about that as we move to triplets. How can we get adequate drug into patient? Not too much and not too little. And that might be by limiting duration, it might be by sequencing, but I think that's going to be a theme as we move into more combination therapies. So I put just sort of arrows there. The Cabo dose, which started at 40 in the triplet arm, was about half, so median dose of about 23. The number of doses of Ipi received, you see there was about 15% less patients who got four doses versus the doublet arm, and 15% more who got 2 doses. So basically a subset of patients, instead of getting 4, got 2 is one way to think about it. Whether that'll have long-term effects, we'll see. But it's clearly a number of doses of Ipi needed is of course not well defined. And this is a slide that I stole from Monty, and the next one as well. I didn't ask you, but I stole them. So in my opinion, the toxicity really limited drug delivery, right? And you can see sort of the various numbers for, again, how many patients were able to get all 4 doses of Ipi, and then correspondingly the need for high-dose steroids. And we participated in the study, and this was our experience as well. So again, it's about being able to adequately deliver drug at some level. And then again, another slide from Monty's excellent discussion is about shrinkage. So we said, well, when you add in a TKI, you get more shrinkage, right? You should get a higher response rate, potentially deeper responses. These are early data, so these will mature over time. I think the response rate will go up. I think the CR rate will go up from this. I think it was 18 months of follow-up. But at least the early data would suggest we didn't necessarily see that in this study. And was it a result of inadequate drug delivery? Was it for other reasons? I don't know. Tony can certainly comment, and we'll see. We'll see as time goes on and these data mature. And this is a poll from our conference last week, and Monty put this up. And so this is sort of after Cosmic. If you just focus on the top one, the bottom one's about doublets. Would you use this triplet if it were approved? And again, you see about 75% saying no, and that corresponds to about that 75% who said they wanted to see an OS benefit. I suppose a separate question is, if the regimen does get approved in those 25%, who would you use it in? I've heard Hans talk about it. Who are the patients where you might think about a triplet? Would you give Cabo forever? Would you give it up front as sort of an induction for disease control? Again, I think we can have that discussion as time goes on. The other large triplet study that's going on is Merck's triplet, which is represented here. So this is a little bit different than the Cosmic study, right? It has a len-pembro control, an IO-TKI control, as opposed to Ipi-Nivo. And then the investigational triplet arms are either adding belzutifan, or HIF inhibition, or adding CTLA4 inhibition. So very different, at least the top one, a very different type of triplet. And it's probably that these triplets may apply to different biology, right? You can imagine HIF inhibition might be more effective in a more favorable risk, whereas CTLA4 inhibition would be more effective in an intermediate or poor risk. So this trial is accruing well. We'll see. Actually, the numbers are now up to 1,600, so it's a bit of an old slide. But this is ongoing. It will be the next large triplet data that comes out. I'm sure will teach us a lot of lessons about application of this therapy. And then, sorry about the busy table. This is sort of just putting everything on one table. Again, I've only included one of the IO monotherapies, KEYNOTE-427, the IO-based doublets, and then now layering in sort of the triplet therapy from Cosmic. And so these data are evolving over time, right? And there's a lot of limitations to these tables, I understand. But I think it sort of gives us a big picture of what are we doing? What's the data? What's the response rate, the CRA, all the sort of relevant numbers, as we go through. And it's great to see this much drug development in kidney cancer, right? There was a time where there would have been maybe one column on this table of interferon. So it's great to see all these doublets and triplets. I think there's a lot of drug development. I think we're doing a better job of controlling disease and curing patients in frontline kidney cancer, but with a long way to go. So just to wrap up, IO-based doublets, I think, are the initial standard of care. Pick your favorite. I don't give much monotherapy. In really frail patients, I'll give IO monotherapy. I don't give TKI monotherapy to anybody. I haven't done it in many years. I think duration of TKI or duration of therapy in general is a undefined topic, and we need to think about de-intensification as we get more drugs and mechanisms to start to put them together. I think we'd all agree that we lack clinically useful biomarkers. I mentioned sarcomatoid, but aside from that, we're empirically selecting therapies, right? And we all have our own bias about, I like this regimen, you like that regimen. But I don't think we're really doing a good job of developing biomarkers. And I think all of us, many of us, everyone in the room is focused on that. And then triplets are, we sort of had the first opening data for triplets. I don't know that in an unselected population, maybe that's going to be a good strategy. We'll see as other triplet data comes out and Cosmic data matures. But I think it's maybe going to force us as a field to be a little smarter in application, smarter in duration, and some of the things that I talked about. And thanks for your attention.
Thank you. Thank you, Brian. So we're going to leave the questions to the end and jump to the other extreme, talking about actually adjuvant trials in renal cell cancer with Dr. Powles.
Thanks, Tony, and thank you for inviting me to come to your beautiful city in Philadelphia. I saw Rocky this morning. It was very inspiring. I felt he was in the wrong place. He should be at the top of the stairs, not the bottom. But anyway, that's my. Look, we're kind of. Will you let me know when I get here? I've got 15 minutes. Is that right? Could you be in charge of time?
Yes.
If I yeah. Okay, great. So if I overrun, let me know. Okay, so I've got a number of conflicts of interest. I think we're reaching a really important time in kidney cancer. I've got 2 disclosure slides, which is terrific. It suggests I've got many disclosures. We've obviously got this very positive pembrolizumab study. We know about this study. We've talked about it a lot. It hits a PFS signal. It's a very powerful disease-free survival signal. Significant reduction in the risk of the cancer coming back. It has FDA approval, it has EMA approval, is recommended by all the guidelines groups. It has a trend towards overall survival. The reason why this trend towards overall survival is important is you're able to say to patients, we don't know what the long-term survival is. We all agree survival is important, but this is going in the right direction. And if it continues as it is now, then there will be a survival benefit. Without that survival signal, there's more speculation, because how do you know that subsequent therapy won't rescue patients, etc.? So there's a 10% chance of life-changing toxicity with these drugs, and that needs to be discussed with patients. There's a degree of uncertainty, as I've said before. The kidney cancer story so far has been a story of real success until recently. And that story was just a series of positive trials. One of the issues with continued success is you don't have to ask difficult questions of yourselves and the community. And the reason why that's the case is everything's working very nicely. But you'll see by this slide, and there's a bottom, the first negative frontline metastatic combination immunotherapy study with PEG-IL2. And then, of course, these series of negative adjuvant and neoadjuvant studies have come through. And that means we probably do need to pause for breath at this point as a community and either decide whether we're going in the right direction or whether we need to change direction. And that's probably the first time we've been there for a decade. Until now, we've just had a series of positive trials, everything's worked, and it's been successful. I speak to many people around the world, and I hear very divided opinions for the first time as well about where we should go next. And what I'm describing today is some trials which I think may help us make that decision. While these trials are negative, actually it's possible we'll learn more from the negative trials than the positive studies. I think it's extremely important we don't ignore the negative trials and just say, because they were negative, we're not going to do that. We're just going to give everyone pembrolizumab. I do think we need to think very carefully about why they were negative. I'm not going to talk in detail about the differences between the studies. I would say the 3 adjuvant trials of Totalizumab, pembrolizumab, and nivolumab, ipilimumab, I'm not going to call them by their numbers because it's too confusing, have more similarities than differences. If you look at the outcome of the control arm of their trials, they're very, very, very similar. That's the best way of telling what the risk group was, what proportion of patients relapsed. Not necessarily about the TNM classification. And yes, there were some M1 populations in some and not in others. But when you look at the subset analysis without that, the pembrolizumab trial is still positive. The perioperative, it's not a neoadjuvant trial, the perioperative PROSPER study gave a cycle of nivolumab prior to, and then a series of cycles after nephrectomy. That trial did have differences in its design. There were important differences in the design. The population was a lower risk population. It did have a mixed population with non-clear cell patients involved at all. It was an open label trial and the study arm required a compulsory biopsy. All of these issues are going to add noise to that study. Also, a number of patients didn't go on and get a nephrectomy. That study is outlined here. You can see the arms are not exactly balanced, and when you put in balance, it creates uncertainty. And here's a list of just some of those uncertainties. The thing we'd really like to see, I'd really like to see in this study, is the consort diagram to see what actually happened to some of these patients. This trial does not mean that nivolumab as a single agent would not be a positive trial in this setting. It's very important to recognize that. And indeed, there is a randomized trial ongoing within the IPI-NIVO trial, which explores single-agent nivolumab. So in my opinion, it's currently premature to say nivolumab is not active in this setting. This was an investigator-initiated trial. I've done many investigator-initiated trials. They're extremely difficult to do. The budget is 1/10 of a big pharmaceutical budget. It requires goodwill of the community. And this was a Herculean and spectacularly successful effort in that respect. And the United States and Canada that performed the trial should be proud of the excellent work that they've done. There are some statistical issues and some analysis issues. Those individuals who didn't have nephrectomy in this neoadjuvant trial were considered to have an event. In my opinion, not having a nephrectomy shouldn't be classified as an event. What is an event? An event is supposed to correlate with overall survival. That's the point of events. And clearly not having a nephrectomy doesn't necessarily mean that patient's going to die more quickly. That's an issue for the team, and they need to go away and have a think about that. That's my personal opinion. There's probably one or two statisticians who happen to agree with me, but I'm sure we can find others who will disagree. The follow-up of this trial is actually relatively short, and there's quite a lot of censoring. So I think we do need to see more mature data. I would also like to see the overall survival data. There's a huge amount of work to do in this study. I'm also super excited about the biology with the sequential tissue. So a fantastic effort. We don't know enough about nivolumab in the adjuvant setting yet. Let's not be premature, and let's look at more data from this. I apologize. I'm also going to show Twitter polls. I'll be very, very quick. I was really interested to see the result of this Twitter poll. Actually, 120 votes, not as many as Brian's. That's the case in my life. But low-risk patients included as the main reason. I don't agree with that, actually. I think there's too much noise in this trial to, I think low risk actually contributed towards it. But if it was low-risk patients, you'd expect a trend towards the curves going apart a little bit and perhaps some other issues in the forest plot analysis. We move on to the Totalizumab trial, a really well-conducted study published in the Lancet recently. A randomized phase 3 trial. It's got the same endpoints as the other studies, the other adjuvant studies. And you can see here, no disease-free survival or overall survival advantage. The beauty of this trial is it is so negative. And the reason why that's beautiful is you can say this didn't work. Unlike nivolumab, there's some uncertainty. And so we have to work out why this trial didn't work and why the pembrolizumab trial was successful. The community feels that PD-L1 inhibitors are less active than PD-1 inhibitors in kidney cancer. That seems to be something which is growing in momentum. We as a group need to think carefully about that. We're doing a lot of the biology, a lot of the translational research, we're doing off the back of PD-L1 inhibition. We've seen a Nature Medicine publication with Totalizumab and pembrolizumab. We've seen Cancer Cells and Nature Medicine publications with atezolizumab, bevacizumab, and nivolumab, and axitinib. We need to do biomarker work with PD-L1 inhibition. Sorry, PD-1 inhibition, because that's the drug that works. So let's be thoughtful about that, and that's where I come back to at the beginning before we think too much detail about that. However, it is worthwhile remembering that single-agent atezolizumab does have significant activity in clear cell kidney cancer. Indeed, in this study, 11% CR. It was a small study, but those people who say atezolizumab has no activity in kidney cancer, that's not correct. It does have activity. So there is a bit of an imbalance here. A very, very negative adjuvant trial, but we know the drug has activity. Indeed, it even has CRs. Quite complicated, in my opinion. And then perhaps we come to the most complicated issue of all. I don't think anyone in the room genuinely thinks that ipilimumab and nivolumab is not active in metastatic kidney cancer. I think most people in the room would accept that ipilimumab has some activity and some additive activity, although I agree the 8x8 trial is going to turn out to be very important. I think most people believe that ipilimumab is associated with durable remission, and therefore in an adjuvant setting it should work well. This again is a very negative study. We've not seen the overall survival signal. I really would like to see that. You might say the study is immature and it's premature. I'm not sure that's right. You would expect the curves to be going apart a little bit. That's clearly not the case. The most plausible explanation as to why this trial was negative, if we put the drugs to one side, which I promise I will come back to, I promise. Two issues. Number one, it's 6 months of therapy, not a year. But then Mike Atkins at the front row has always said to me, Tom, that ipilimumab is particularly active at the beginning. You don't need to give it for a long period of time. But then some people might come back to me and say, well, actually, the ipilimumab was dripped in. It wasn't given all at the beginning. It was given in an unorthodox regime. The second issue, of course, is around the toxicity. Were we able to get the drugs in? Brian's just given a lovely talk about cabo, ipi, nivo. One of the conclusions, in my opinion, of that is it's quite difficult to give all three drugs at the same time. And by trying to give them together, you may actually not give any of the three of them brilliantly. Is it possible that this was the case with ipi, nivo? Well, it's conceivable. You can see higher toxicity, and there was higher toxicity for ipi, nivo than atezo or the pembro trial. The community feels the same way about the toxicity issue. I think that's reasonable. I did say I would try and address this ipilimumab issue and to say that, do we feel how much is ipilimumab adding to our drugs in kidney cancer? And I think we do need to ask ourselves that question. We haven't done those randomized trials. You'll be aware that the EMA initially rejected ipilimumab and nivolumab in kidney cancer, which I disagreed with strongly and was part of the process of appealing, actually reversing that process, which is one of the things which I think we as a group were most pleased with. And the reason we were able to reverse that was it was clearly better than sunitinib. But the EMA came back and said, how do you know nivolumab by itself isn't better than sunitinib? And indeed, the 8x8 trial, I hope, will address that question. Do we know how much IPI really adds at this point? I'm not sure we do. I think we have to have that debate, because if we have a negative study in the adjuvant setting, and heaven forbid if 8x8 comes back and shows that it's not adding very much to nivolumab, we are going to have to actually ask difficult questions. I know organizations like the EMA will ask those difficult questions, otherwise they wouldn't have asked for the trial in the first place. So in summary, I think it's reasonable to say the pembrolizumab study was strongly positive. The data is clear. That wasn't a lucky event. Actually, it's a 1 in 10, if you look at the p-value, it's a 1 in 10,000 event. It's got a PFS signal and a trend towards overall survival. And it's pivotal in that respect. But it is also worthwhile looking at the PD-L1 story, and that story has losing momentum. I think it's reasonable to say that our community currently feels, unlike in the bladder cancer environment, that PD-1 is preferable to PD-L1 in kidney cancer, although we've not done randomized trials in that respect. I think we need to park this neoadjuvant study. Someone came to me the other day. It was a group, actually. It was a group of people. We're trying to design things for the future. And the question was, should we do another neoadjuvant study, or is the neoadjuvant environment dead? And actually, we had a melanoma doctor in the room. And as you'll be aware, the melanoma neoadjuvant story is gaining momentum, not losing momentum. And indeed, there was that terrific neoadjuvant study with radiotherapy and rectal cancer with Ipi-Nivo at ESMO. And so the global community wants to do more, not less, neoadjuvant work. Are we in the renal community going to swim in the other direction? I'm not sure the answer to that question, and that's a question I'd like to answer as well. The next question I'd like to answer is, how do we feel in the community about ipilimumab? Are we clear about its role? And if we are clear that it's active, what's gone wrong in this particular trial, and what happens if 8Y8 is negative as well? I think it's reasonable to say that this is not an exact replica of the VEGF TKI data. I've not shown that data, but I'm happy to have that discussion. I think this story is different, and it needs to be considered differently. And then I think the last thing I think is super important is during this debate, which we as a community need to have over the next year, because the trials we have done now, there are very few new trials coming out asking completely different questions. And that means we're going to plateau probably for 5 years. And two key questions is, can we select patients for therapy? In the adjuvant setting, we're clearly over-treating 50% of patients, number one. And number two is, how much therapy do we need to give? And I completely agree with Brian, giving lifelong VEGF-targeted therapy is not in the patient's interest. How come in the community we've now been going with these drugs, VEGF-targeted therapies, for such a long period of time, but we now have no idea how long we're supposed to be giving these treatments for? I guess the last question is, what should we be telling our patients? And I think we need to be telling our patients the entirety of the data. I don't think you can just present the pembrolizumab study to patients, as I don't think you can present just the atezolizumab study to patients. I think we need to be telling patients that we have a positive study, we can delay disease-free survival with pembrolizumab, which is robust. However, there are data with other drugs which we thought would be quite similar, which have turned out not to replicate that result. The reason I think these adjuvant trials have not been successful, and the reason why we have mixed results, and the reason why I am unable to explain to you exactly what's happened, is not just because of my own shortcomings, although that is part of it. The other part of this is there will be multiple reasons why these trials are failing, some of which might be down to chance and patient selection. Nevertheless, it's clear we have a big story to unfold over the next 5 years, and we need to do more trials to explore that. Many thanks for your attention.
Tom, this was great for two reasons. You were on time.
Oh,
And I've never seen someone, only Tom can pull, linking Leo Tolstoy to kidney cancer, among others. So
And he managed to not spill his can of Coke that was just hovering
Yeah.
on the
45
podium.
degrees.
We were like,
And Monty get handed coffee on stage. That's also a first.
Yeah.
So, I mean, this is a first. So again, we're going to leave the question to the end. And now we're going to have Dr. Martin Voss from Memorial Sloan Kettering. He is going to be tasked a difficult task, defining the second-line treatment in a place where most of the trial are conducted in first line now.
Okay, thank you so much. So yes, summary of second-line trials and beyond. So there's a lot less data for us to review than in the first line. And I want to thank you nonetheless for inviting me to speak today, and thanks everyone for coming to the early session. In my disclosures. And drug development and the evolvement of a treatment landscape is a function of time. So I think it is important that we look back. There's one slide on a historical perspective to developing drugs second line and beyond. So if we go back to the mid-2000s, when targeted therapies were first established as standards in this disease, there was a concerted effort to then develop regimens specifically in patients who had been pre-exposed to said drugs. So after we had sunitinib, sorafenib, pazopanib, there were registration trials specifically conducted in the second and third line space. And you see here on the timeline up on the right, highlighted in red, there were a number of registrations that came through in the course of the next 10 years that specifically defined how to use drugs in pre-treated patients. That went on for about a decade, and by 2018, and that's the cartoon at the bottom, we had a pretty good definition of how to sequence drugs based on pivotal phase 3 data, but also based on switching mechanisms of action. And it seemed pretty straightforward at the time to figure out how to travel through lines of therapy, at least for the first 2 or 3 lines. More recently, past 2018, that has changed in that with the advent of immuno-oncology drugs, and again, the first approval for an IO agent, nivolumab, was actually in pre-treated patients. So Checkmate 025 was a second, third line trial, but past that, the effort has been very much focused on the first line and adjuvant space, and we've heard all about that in the last 2 talks. So you see here in the pink box towards the right that since 2018, there's very little that's been happening in terms of approvals for pre-treated patients. And in part, that is because we've all recognized that moving IO as early as possible into sort of the lifetime of a patient's treatment journey is very relevant, and that IO works best early. That certainly is the case not only for CTLA4, but also for Pd1 inhibition. I think it's secondly also because companies have realized that there's many more patients in the first and in the adjuvant space, so there's just more to be gained by approving drugs in that space. And I'm not going to talk about all the first-line regimen that came since then, but it has had 2 effects. For one, and we've heard about that, we've had a lot of options for our patients in the first line, and that's great. And we've pushed the needle for overall survival based on the efficacy of these first-line regimens. But secondly, the previously defined sequencing strategies no longer apply the way they did before. So again, on the top, you see how one might have sequenced things up until 2018. We would have started with a TKI monotherapy. You would have gone on to a second TKI or an IO regimen, and then you would probably switch mechanisms of action again in the third line. Beyond that, it's sort of a freebie, at least if you're in the US and you're not capped by how much drug you can give. But since 2018, with the first line doublets, we don't have data that, or we didn't have any data that would really tell us what to do beyond IO-IO or IO-TKI. So for the purpose of this talk, what I'm going to do is I'll walk you through a couple of slides to now talk about what we've since then learned, how we can use data on existing drugs, so drugs that we already have in the clinics, and what our sense is as how they perform in this space. And then secondly, we'll talk about ongoing efforts in the second and third line. So the most recent TKI approval, the FDA label came in 2021, is for Tivozanib. So Tivozanib is a very target-specific VEGFR2-directed TKI that was FDA approved based on the TiVo-3 study, which you see highlighted here. And there's a general assumption that because it was approved in 2021, it must be contemporary data that applies in an IO pre-treated patient. That's actually not the case. So the majority of patients that went on TiVo-3 had never seen an ICI drug before. About a quarter of the patients on the trial were immuno-oncology pre-treated. And you see here on the left the schema of the study. So this was a phase 3 randomized study comparing Tivozanib to sorafenib in patients who had had either 2 or 3 prior lines of therapy, so heavily pretreated population. And I think the company has to be commended for defining the treatment space a little bit better and going after this particular population. They were randomized to receive those 2 drugs, and the primary endpoint was PFS. On the right-hand side, you see a Kaplan-Meier curve that summarizes the efficacy in ICI pre-treated patients. And again, that's a small population of patients, about less than 50 patients on each arm that had immuno-oncology drugs, and Tivozanib is better in that space and has a median PFS of around 7 months. We have more data for Cabozanib, and that's probably the most commonly used monotherapy TKI in that space. Again, Cabo was originally approved in the pre-ICI era based on the METEOR study. So the label came in 2015, but there's more data that has come in since then. This is relevant data from Cantana. You've all seen this before. Cantana was a randomized phase 3 study that tried to establish glutaminase inhibition in kidney cancer, and it was a negative trial. So the trial compared Cabozanib plus placebo versus Cabozanib plus telaglenastat. And this is, again, a subgroup analysis here. There were more ICI pre-treated patients on this study, about 130 in each arm, and it helps although it was a negative trial, that it defines for us how well Cabo performs in these 130 plus patients. And it is, projects sort of the bar that we now have to compare current efforts to. So median PFS of around 9 months, response rate somewhere in the low 20s. That's how cabozantinib, should work in IO pretreated patients. What about IO subsequent to prior ICI therapy? So this data has not been published, but it's been presented in abstract form. This is Fraction, and Fraction is a phase 2 study run by BMS that has different tracks. And track 2 is pretreated patients, so all patients summarized here. On track 2 had received prior IO therapy. About 46 patients were treated and now received ipilimumab, nivolumab. So it gives you a sense for how CTLA4 inhibition performs in a PD-1 pretreated population of patients. And it was sort of the smattering of combination of monotherapy PD inhibition prior to going on to this. And there's a response rate of about 15%, no CRs. So we always set the bar super high for CTLA4 combination based on the toxicity, but it is important to recognize that there is efficacy. So yes, patients can respond who have not previously had CTLA4 therapies and now receive the combination at the price of the toxicity we always talk about. And the responders on this study, which was 7 patients who had a established response, there was only 1 IO TKI pretreated patients, some Nivo monotherapy, and there were a number of Nivo LAG-3 combo treated patients who had received therapy on trials previously. Okay, what about TKI Io after PD-1 inhibition? So this is data that was published in Lancet Oncology last year. This is a phase 2 study that's pretty sizable, co-run by Eisai and Merck, lenvatinib, pembrolizumab, which of course we all give all the time now. And this included patients who had and those who had not received prior ICI therapy. The majority of these patients, about 100, had been ICI pre-exposed, and those are the blue patients on the right-hand side. And you see there's clear efficacy here. This included patients with prior Ipi-Nivo, patients with prior IO TKI, and patients with monotherapy, and the response rates were somewhere in the range of 60%, 40%, 50% for those respective subgroups. So clearly a very strong, promising signal, and that has given a lot of energy to ongoing efforts. As a phase 2 study, by no means is this definitive, but it very clearly brought home the point that you can probably sequence combinations, and that's really what's going on right now. So with that, we can move on to ongoing efforts about randomized trials that have not been reported yet. So we have a sense now for how the drugs we have on the shelf perform. How about drugs or combinations that are being developed? And I mentioned IO-TKI works well in ICI pretreated patients. So there are 2 large phase 3 studies that are worth highlighting. This is CONTACT-03, which is run by Roche and is a randomized study that brings on patients who have had prior progression on ICI PD-1-based regimens. That includes patients who have had adjuvant ICI therapy. This study has fully accrued. It's about 500 patients strong, and it randomized patients 1-to-1 to receive either cabozantinib alone as a standard in that space. I think that was appropriately chosen versus cabozantinib plus the PD-L1 inhibitor Totalizumab, and we know that that regimen is safe and effective based on phase 2 studies that have been previously reported. There's randomization by IMDC risk, and also importantly by when the patients had had prior ICI therapy. And the primary endpoints are co-primary endpoints of PFS and OS for this study, which hopefully is going to show us some data by next year. This is TiNivo-2. It reads very similarly in its design. So this is a study for patients who have had no more than prior Pd1 TKI, but must have had prior ICI exposure, and they're randomized to receive either tivozanib, which is given a little bit earlier here than on it per its label, versus tivozanib plus nivolumab. And again, that is a combination that has been only presented in phase 1b, small data sets before. So 1-to-1 randomization, smaller study, about 300 patients. Primary endpoint is PFS, and that's currently still accruing. We've heard at this meeting a lot about HIF inhibition. So HIF2 inhibition, belzutifan, has an FDA label. And remember that that label presently is only in the syndromic setting. Only patients with RCC in the setting of VHL syndrome are currently approved in the United States to get belzutifan. There's a number of studies that are being run, and there's 3 that I want to highlight here, looking at monotherapy and combinations in pretreated patients. So this is a phase 3 study with patients who, again, have been pretreated with a PD-L1 inhibitor, Pd1 inhibitor, max 3 prior lines randomized to receive everolimus, talk about blasts from the past, versus belzutifan here, 1-to-1 randomization, 700 patients with PFS, OS co-endpoints. This is now belzutifan in combination. So again, pretreated patients, PD-1, PD-L1, max 2 prior lines, randomizing 700 patients to receive either standard cabozantinib versus belzutifan plus lenvatinib. And again, the same co-primary endpoints. And then thirdly, and that's a smaller study, not a registration trial, but I think it's very interesting and worth highlighting because we talked a little bit about that concept during the IIT session yesterday, CDK inhibition. So this is LITESPARK-024, which brings on patients with 2+ prior lines, prior ICI exposure, and tests the combination of HIF inhibition with a CDK4/6 inhibitor, palbociclib. So randomization, belzutifan monotherapy, assuming that it's going to be a standard, I guess, at some point, versus belzutifan plus palbociclib. So very interesting. And this is, early in its development. So I think appropriately the response is the primary endpoint here, looking into this. And then lastly, and very importantly, this is, there are adaptive studies that we've talked about a little bit at this meeting, and there's one that is relevant and ongoing. So although it starts in the first line, it extends beyond the first line itself, and I think it's worth highlighting because I think it takes an important path of trying to individualize how we approach second-line therapy. So this is Pedigree, which treats patients in the first line with ipilimumab and nivolumab, and then based on how they respond to that, searches for the next step here. So patients with CR go on to nivo maintenance, patients who have primary progression sequence over to TKI monotherapy with cabozantinib, and those who have neither a CR nor progression are randomized to receive further nivolumab as a standard currently versus nivo-cabo as the investigational arm. So as we do all this, we're defining new ways, and I should again come back to say that and you can tell from how these talks go. There's so much to discuss about first line and adjuvant. There's very little as of yet to discuss about second line and beyond, but you can tell from these trials there's level 1 evidence coming our way, and certainly everyone is going to see if we find ourselves doing what we did 10 years ago when we learned that you can go TKI after TKI after TKI. So it's the question. Are we going to go combination after combination after combination? I do think toxicity is going to be at the forefront of making these decisions and seeing is it justified for us to expose patients to so many drugs, over extended periods of time. As we do all this, we accumulate more data and more FDA labels. A lot of people comment that we have too many labels and we keep doing the same thing over and over again. But I think on behalf of our patients, we have to recognize that it's just wonderful that we have so many options to consider. It's more difficult to define a path, but it helps us certainly to offer our patients the best shot at getting better. So in summary, we do not have a well-established sequence beyond the first line presently. We have a lot of confusion in the first line and more confusion in the second line. Common practice for all of us is to use off-label drugs that are on the shelf, and I would caution that I think there's too much off-label combinations in the second and third line just because we all assume that must be better. I think it's important that we wait for the prospective data to help guide. There are ongoing efforts that are following certain themes. Sequencing combinations is something I keep coming back to. Novel agents, I do think that the HIF inhibitor, and there's more than one drug now, are tremendously important because it also gives patients a break off of TKI toxicity as we go into the next line. And then thirdly, adaptive designs, there are too few of them. The other speakers have highlighted the importance of developing biomarkers as we go along, and there's even less of that going on in the second line. If you think about how we've done this on trials up until now, is we collect archival tissue that was collected before the patient even had their first line. So a lot of the second line trials diligently collect slides, but the slides are like on average a year to 5 years old. I don't know that that's the right way to approach understanding what biology is in the second line and beyond, and how it should inform what we do. And the same should be the case for how the patient responded to the first line. So I think these adaptive designs are tremendously important, and they are on the right path for us to do better in integrating the first line experience of individual patients into what we do beyond that. And with that, thank you for your attention.
Thank you. Outstanding talk. This was not easy, Martin, and you stayed on time, and you did not provide any scientific Twitter polls.
Thank you. Twitter polls, I'll send them.
Yes. So, pleasure to introduce my good friend, my mentee, and my great collaborator, Dr. Laurence Albiges, who flew all the way from Paris to talk about microbiome. Her institution, if you're not aware, was one of the first in the world to introduce microbiome in oncology through her collaboration with another Laurence, Professor Laurence Zidvogel. And again, we have Monty here, who hopefully in the Q&A will talk about his work and his clinical trials in the microbiome. So Dr. Albiges.
I want to thank KCRS, I want to thank Hans and Tommy for the opportunity to be here. It's actually two of us physicians from Europe here, so I'm very pleased to be part of this selection. And so I've been asked to cover the question of microbiome. All good? Perfect. So these are my disclosures. And as Tony highlighted, the work I will be presenting has actually been led in my institution by these ladies, especially Laurence Zidvogel, the first on this slide, who really paved the way for microbiome discovery and has now with her working two fellows that are heavily involved in RCC and the link between microbiome and RCC. So the way I would like to frame this today is the following. Microbiome, although we were all very skeptical initially, has now been defined as an established hallmarks of cancer. What was the process that led to the fact that microbiome has such an emphasis today? And ultimately, what are the clinical trials that are ongoing? So, story started about 10 years ago now, where very first demonstration of evidence of the gut composition seems to impact the response to immune checkpoint inhibition. And since that day, over about 10 years, there has been tremendous efforts to define that. And if you pay attention to those, like very important manuscripts for our fellows, you can highlight that microbiome appears as a new hallmark of cancer, defining its role in the response to our systemic therapy, and especially immune checkpoint inhibitor. That took 4 steps to be defined. The first demonstration was the connection between use of antibiotics and impact on response to immune checkpoint inhibition. And let's say by chance, this started with RCC. So very first reported highlight that the use of antibiotics reduced the response to immune checkpoint inhibition. I was highly skeptical when Laurence Zidvogel came and say, well, we should look at that in our data sets. I say, it's just because our patients are doing poorly, then they may require antibiotics because they have, intercurrent infection. So the work that has been done is actually to adjust for other known prognostic factors. And what has been demonstrated in RCC in one small study was subsequently demonstrated in many cohorts, including over hundreds and hundreds of patients. This is a summary outside of RCC, but only in GU field, highlighting the fact that a patient receiving antibiotics while receiving immune checkpoint inhibitor actually had a dismal prognosis, both in terms of PFS, response rate, and overall survival. So there has been many meta-analyses. And what the doctor looked at was to look at, is it exposure to antibiotics prior to immune checkpoint or very early on when the patient is receiving your IO compound? And all of which very consistent with the fact that early exposure to antibiotics seems to be associated with a worse prognosis. The second step was to look at the exact composition of bacteria within the stool of patients. And so that took further work to look exactly at the species that were associated with the use of antibiotics. So that was the first demonstration of, yes, there is a prognostic value, but it seems to be a difference in the way the microbiome is characterized in those patients. And this characterization led to the identification of bacterial species that were associated either with response or with progressive disease. So there was more and more granularity to understand what are the species that could be associated with a better outcome. And this work has been done not only in responding versus non-responding patient, but very interestingly, in patient with cancer versus patient without cancer. So that started to be a big deal because it was about what they call dysbiosis, meaning the fact that a patient having cancer actually has a different gut composition than a patient that doesn't have cancer. So that led to the identification of different species that were associated with either pattern of progressive disease or cancer itself. Further work went on to characterize not only baseline species, but also how those species are evolving over time. Yesterday, during this excellent dinner, someone came and discussed that with me. It was, do we have what we could say longitudinal follow-up? And the answer is yes, we have, and it has been elegantly presented at this ESMO. We have longitudinal follow-up showing us that there is differences depending on the exposure to systemic therapy that would actually be associated with gut composition, with different species increasing over time or reducing in responding patients versus non-responding patients. One of them, and this name is important to remember, is what is named Akkermansia. Akkermansia seems to be overexpressed in patients who are responding to immune checkpoint inhibitor. And that could be a potential interventional strategy. And I'm going to get to that point. Akkermansia seems to be highly associated with response to immune checkpoint inhibitor. Therefore, a patient having this bacteria seems to be higher benefit. And so several studies, and I know it's a busy slide, but it's just for you to show you that many reports now have highlighted which are the species that seem to be associated with response versus those that are associated with progressive disease. Why is that important? Because as soon as you understand that, you could start telling yourself, well, maybe I can actually rescue progressive disease or at least try to prevent progressive disease by some intervention. And so we're moving into the mouse model step now. That's the third step. The first one was antibiotics. The second one was gut composition. And the third one is mouse model. What those mouse model has shown us is that, this is in non-small cell lung cancer, but the idea is the same, is that using FMT, so feces microbiota transplantation, you're actually able to restore sensitivity to immune checkpoint inhibition. These are mouse models. It has been developed, and it's highlighting again this Akkermansia bacteria, for instance, that seems to be a key player in restoring the efficacy of immune checkpoint inhibition. Ultimately, I mentioned a lot of species, but I did not mention a lot about diet. And similar funding have been highlighted with the use of a ketogenic diet. So it's either the gut microbiome species themselves or the way here the mouse are being fed with some ketogenic diet. So we're able to impact the composition based on the diet that is being used, at least in mouse model. So we're going to jump now into patients. And that's the first and last step. In melanoma field, it has been established through different reports that you're actually able to restore sensitivity to immune checkpoint inhibition with feces microbiota transplantation. So it means that in a patient that have progressive disease, by changing the gut composition, you're able to restore response to immune checkpoint. The most important study was actually led by Monty's group. And Dr. Tisman and all the team should be congratulated for that trial that was recently presented and published. Why is that? Because it's a randomized prospective study. Looked at the patient that were receiving doublet immune checkpoint inhibitor, namely nivolumab plus ipilimumab, and prospectively assessed the use of a probiotic agent on top of the immune checkpoint inhibition combination. So it's not a large study. It's a 2-to-1 randomization. Twofold higher number of patients in the experimental arm. What I like about this study is that very pragmatically, the endpoint was gut composition. And ultimately, it wasn't obvious that there was such a difference in gut composition. However, what was obvious is that this strategy was associated with a clear benefit in terms of PFS, and OS is not, designed to be powered to answer the question. But look at the response rate. There is also a clear increase. It's not statistically significant because the numbers are small, but there is a clear increase in patients that have objective response with this strategy. So that study was the turning point to me, demonstrating that all the rationale is actually applicable into a prospective strategy, and we're able to do some intervention. So I'm going to move now on the clinical trial that are ongoing. So for the purpose of today, I went online and checked, okay, how many trials are either related to microbiome, probiotics, microbiota, and RCC. And so I could find 17. So I review all of them for you today. They're either the descriptive approach and like very large prospective, still observational study looking at gut composition. I think we're past that point. We're beyond that now. Or there are the interventional studies with two different strategies. One of them would be to be able to increase efficacy of our current agents, and one of them would be to reduce toxicity. What would be the intervention that we could consider? It could be FMT, as we've seen not only in mouse model, but also in patients with melanoma. It could be diet. It could be handling stress. It could be many other items that are highlighted here. So don't worry, I will not list the 17 study. I just made some pick. So one of them here, I think it's very relevant. It's looking at the prevention of high-grade toxicity. It's not to treat a toxicity, it's to prevent a toxicity. So this is a small study, it's a phase 1, but the endpoint is to look at the occurrence of immune-related colitis related to IO strategy. This is a very valid approach to avoid toxicity with potent immune checkpoint inhibition using feces microbiota transplantation. The second one from Monty's group as well is looking at the combination of the same agent, the probiotic that I mentioned earlier, CBM5A8, in combination not only with IO strategy, but IO-TKI. Why is that important? In the sake of time, I didn't show all the data, but our TKI are impacting gut microbiome. So maybe the right venue for this probiotic is actually in combination with TKI, given that TKI themselves are clearly making some change in the gut composition. And here the endpoint is not only descriptive, but the secondary endpoint is to increase toxicity efficacy of our strategy. The third one I want to highlight is a trial that was just launched in my institution, led by this young lady, Emeline Colomba, which is about diet. Here, patients are either receiving ketogenic diet continuously, discontinuously, or even ketone bodies with regular diet. So this strategy, once again, is here to increase the response rate. What we're trying to do is increase efficacy of treatment. And one of the last one, I think is very promising as well, is just to rescue strategy. So basically, you will have an intervention only in patients that have progressive disease. I'll finish on that one because that one is one of the first to be biomarker-based. That is another trial just launched. That is a phase 1/2 with Akkermansia, the species that I mentioned earlier. And here patients are screened to know if they are at baseline having this bacteria or not. And the intervention is only in patients that are not carrying this bacteria within their gut composition. So what are my take-home message around all those trials? The first one is microbiome is clearly a field of research that is still in expansion. Second, that cancer is inducing what we call allelopathy. So basically changing the gut composition. That this gut composition is associated with distinct response to immune checkpoint inhibition in terms of response or progression disease. That this microbiome represents a new biomarker of immune checkpoint response, and therefore we are at a stage where we have now interventional studies that are ongoing. What are the open questions? Well, we are ready for intervention. However, we don't know yet which intervention. Will it be FMT? Will it be diet? Will it be just probiotics? In which patient? Should we select patient ahead? This is something that Laurence Albiges is a strong believer. She said, Not all patients should receive that. We should screen the patients that are more likely to benefit from this approach. And ultimately, should we use that as an upfront or as a rescue strategy? With that, I would like to thank you very much for your attention.
Excellent. So I introduced Dr. Albiges as Dr. Albiges, but just a couple of weeks ago, I think she's one of the youngest professors at Gustave Roussy. So congratulations and a round of applause.
Thank you, Tony.
Okay, so let's move to non-clear cell RCC. I think Monty was only aware a couple of hours ago or yesterday, Tuesday night, that he has to talk about the non-clear cell RCC with a focus on papillary RCC. As we all know, he has been a leader in the field, proven by the trials. You know, he led in this, rare variant of RCC. Monty, all yours.
Oh gosh, and I have to tell you, on top of not knowing that I was responsible for giving this talk, I also didn't realize I was going to speak after Laurence, and that was probably the best update on microbiome I've ever heard. That was really, and well worth the trip from France. So thank you for being here. I will outline some of the updates in non-clear cell kidney cancer, and I'll kind of take a little bit of a different approach. I'll focus principally on papillary RCC, but my last couple of slides actually incorporate a couple of updates, actually principally from your presentation, Laurence, at ESMO, and a nice synthesis of a lot of non-clear cell data from Andre Fay, one of Tony's mentees in Brazil. I thought he gave a really nice overview there. I can probably skip past this slide for this audience. This is well known regarding the distribution of non-clear cell subtypes. Papillary is probably the one that we see most often in the clinic. And I'll start with, my typical approach to discussing this with fellows is to suggest that studies that we've done in yesteryear really took this mixed bag approach where we didn't individually assess papillary kidney cancer, but rather we actually threw multiple subtypes together. And these are really critical foundational studies. Nazar led ESPN, which I think is one of the most important amongst these. And I'll use this as an example, but Andy Armstrong led Aspen. The Record 3 trial run by Bob Motzer and colleagues didn't necessarily focus on non-clear cell histologies, but about 10 to 15% of folks actually did have non-clear cell disease there. But you can see that across these studies, there's sort of a hodgepodge of different histologic subtypes. And one of the challenges here, although again, I can't underscore enough the importance of Nazar really sort of taking on this effort for us and really moving the field of non-clear cell kidney cancer forward, is that it's really difficult to sort of interpret across these individual subtypes what we should and shouldn't be using. We have 5 or 6 patients in each of these treatment arms across subtypes. It's hard to say definitively whether or not, for instance, we should be using everolimus or sunitinib for patients with translocation RCC or sarcomatoid RCC and so on. So one approach that we can take is what I'll define as the histologic bag approach. And this histologic bag approach, really involves parsing out the individual subtypes of non-clear cell kidney cancer and assessing specific therapies in that context. SWOG actually took, I believe, one of the initial stabs at this with erlotinib, and this study was reported out back in 2009, so many years ago, with the modest response rate of 11%, 6-month PFS of 29%, and you can see a slew of other studies beyond that. Tony's Ferretinib study, which I think actually had a very impressive PFS of 9.5 months. Response rate, though, kind of consistent with the other studies at around 13% or so. That sort of led to the genesis of a randomized study in this context. We sort of felt the need to really sort of push the field forward and try to do a randomized study specifically assessing papillary subtypes. This study was really predicated on the fact that, there's been a lot of great work, and I'll highlight some of this work, suggesting that MET really drives papillary kidney cancer. So this study used sunitinib as a control arm, which was sort of established by some of the studies I showed on the previous slide as a reasonable control in that context, and juxtaposed sunitinib against 3 MET inhibitors, cabozantinib, crizotinib, and savolitinib. I highlight savolitinib and crizotinib here in red because surprisingly, they actually dropped out at the time of an initial futility analysis in this study. And I'll just cut right to the chase here in the interest of time. This is the bottom line. We saw that there was a significant improvement in progression-free survival with cabozantinib over the control arm of sunitinib, about 9 months versus 5 months in this context. So, we saw, sort of a clean crossing of the pre-specified thresholds for PFS. But not only that, there did seem to be some benefit in terms of response rate as well. The cumulative response rate with cabozantinib was 23% versus just 4% with sunitinib. Really not a lot of responses in unselected patients receiving crizotinib or savolitinib in this context. But we'll talk a little bit more about savolitinib in just a second. I think it's an interesting drug. I always like to cite this work that Laurence did. I believe is part of your PhD thesis, right? Really, for me, illustrates very nicely the fact that, across this very large cohort of patients, 220 patients, that MET alterations really play a key role, not just in type 1 disease, but in a subset of type 2 disease as well. We've done some work with the Foundation Medicine group, me and Tony and others, suggesting again the relevance of MET alterations in the context of type 1 versus type 2. I sometimes favor looking at this data over TCGA because, when you look at some of these cohorts within TCGA, you're really looking at a non-metastatic population. In the context of this Foundation Medicine data set, you're really focusing on those individuals with advanced disease. So with that in mind, and again, I applaud many of my colleagues here on stage for really taking this on. There's an even more honed approach that we can take to non-clear cell kidney cancer, and that's a biologically driven approach. And I think that's perhaps best highlighted to date by the Savoie study that Tony and other colleagues led. What was really the genesis of the Savoie study? What was this observation in this phase 2 assessment of savolitinib that Tony reported out in JCO a couple years ago? That really suggested that if you have MET-driven disease, that's where you're going to get your signal with a more potent specific MET inhibitor like savolitinib. So I thought that this data was quite compelling. And that led to this trial, which I highlighted just a second ago, Savoie, which really focused on MET-driven tumors exclusively. And these MET-driven tumors were defined by chromosome 7 gains, MET or HGF amplification, or MET kinase domain mutations. And you can see the randomization here was between savolitinib at the standard dose there, 600 milligrams daily, or sunitinib at the standard dose. And ultimately, the study was actually closed, not because of slow enrollment or what have you, but there was some data ultimately suggesting that perhaps the sunitinib control arm assessments may have been, a little bit off in terms of initial pre-study specifications. So, ultimately the study accrued 60 patients. I think there was a proposed target closer to about 150, 180, right? But I still think there's really key information that can be gleaned from this data set. If you look to the Kaplan-Meier curve off to the top right there, you can see that there's this slight signal of benefit in terms of PFS. I won't make too much of that, but really when I focus my attention in the bottom right there, and this data is now published in JAMA Onc, you can see this real discrepancy in response rate between savolitinib and sunitinib, about threefold higher, in fact, with Savo versus sunitinib. So, I really do think that there's potential for savolitinib in this context. So I'm going to shift gears there. We're going to come back to the role of savolitinib, but I think I'd be remiss if I didn't discuss the role of immunotherapy. It's been incorporated across all of the talks so far. So what's the rationale for immunotherapy in the context of non-clear cell histologies in general? There's not a ton of rationale, not to say that we haven't looked for some rationale for it. This is work that Tony and Sabina have published some time ago, actually looking at various subtypes of disease and stating for PD-L1 expression there. And maybe my quick and dirty summary of the data in papillary is that there's low PD-L1 expression in tumor, and there's modest expression in tumor infiltrating the tumor microenvironment. This is a component of that paper that we had looking at papillary kidney cancer using the Foundation Medicine data set. And no surprise, papillary kidney cancer is not so different from clear cell in the sense that it doesn't have a high tumor mutational burden. But nonetheless, we do get responses with immunotherapy for papillary kidney cancer. And I've summarized some of the recent studies here. KEYNOTE-427, a really massive and I'd say very important effort from Dave McDermott. This is probably the largest experience we have with immunotherapy in papillary kidney cancer to date, with 180 patients receiving pembrolizumab in the upfront setting. And the response rate specifically within that papillary cohort, not across all the clear cell histologies, was 27%. We've gotten some really discrepant results here. Mike Atkins reported out data from the Hoosier study suggesting that in 19 patients with papillary kidney cancer, response rate was 5%. In Checkmate 920, again, response rates sort of all over the place, and maybe nothing that we can, say that's, sort of expected on this slide here. We across this diverse cohort in 18 patients with papillary kidney cancer, response rate was 28%. So, of course, that begs the question of how well other combinations might work. We've suggested that, cabozantinib has a role in papillary kidney cancer. What does it do with immunotherapy? I'm really impressed at the consistency across some of these numbers. So this is data that Brad had originally presented in the context of cabo-atezo. And what we see here across 15 patients with non-clear cell kidney cancer, and specifically papillary, is a response rate of 47%. I pulled this from Joe Lee's JCO paper. And what's remarkable to me is that the response rate there with cabo-nivo also, 47%. So really interesting. So that was really the thought behind maybe looking at this further. Tony was really a big proponent in CONTACT-3 of incorporating non-clear cell subtypes, so we'll have a chance to sort of speculate as to the role of cabo-atezo there. And we've just launched the study within SWOG 2200. It opened literally, I think, 2 weeks ago now. And that study is going to look at cabo versus cabo-atezo based on some of the signals that we saw in COSMIC-021. So I'm really hoping that we can get your support on this. And we spoke about some of the benefits of doing these papillary kidney cancer studies within the cooperative group mechanisms through the session that Mike led yesterday. Some other updates here, Brad, really sort of continues to pave the way with a lot of these great studies for non-clear cell disease. He talked about CAN-I as well yesterday. This is a paper that he had in JCO, which suggests that the response rate with bev-atezo, maybe no surprise there, is a little bit more modest, around 25%. On the right-hand side here, and this is the only time, Laurence, that I show your waterfall plot from ESMO this year, really striking and beautiful waterfall plot across multiple non-clear cell histologies. But what I pulled from the presentation is that we have a response rate of 53% in papillary kidney cancer there. So, if you look across combinations of, sort of multi-kinase TKIs, cabo or lenvatinib in combination with IO, you're seeing the response rates sort of coalesce in the ballpark of somewhere between 45 and 55%, which I think is very encouraging. This was a study that I wasn't aware of till I came to some of the ESMO sessions, and this is the PAXI-PEM study. So this is a study that's being launched by Sylvie Negrier in France, and this will include 72 patients. And maybe this is something we can discuss, but somewhat unique eligibility criteria. It's going to be open to patients with type 2 or mixed papillary kidney cancer, and it's a randomization between AXI and AXI-Pembro. It'll be interesting to see how this pans out. Do we need randomization in this setting, given these high response rates we're seeing with combinations? I think, the answer to that is yes. I mean, we've been burned by, single-arm studies in the past. So I do think that there's a role to play for many of these randomized efforts. Savolitanib and durvalumab, I mentioned we'd come back to savolitanib a bit later. And so, with savolitanib and durva in combination, particularly in those patients who have MET-driven disease here, really impressive response rate, 57%. This is the genesis of the Sumanta trial, which Tony and Tom are running, which looks at savolitanib and durva versus sunitinib versus durvalumab. So I again think there's very strong rationale, and the study is quite important. In the last couple of minutes here, I'll wrap up by just throwing out some provocative questions more for discussion. Should we offer genomic profiling to all patients? I think the answer is yes. For these rare subtypes, sometimes you run into a needle in the haystack. This is an example of a series of patients we reported out a couple years ago with ALK fusions who actually benefited from therapy with alectinib. So I think there's some role for just discovery in this setting. Cytoreductive nephrectomy, I think the question's sort of still out there in the context of papillary kidney cancer. I don't know that retrospective efforts, although important, like IMDC, fully address this question, and that's what I've cited here. But what I would encourage folks to do is support Ulka's study. Ulka's here in the audience today, and this is the PROBE trial, which is a critical study in this setting, looking at cytoreductive nephrectomy, not just in clear cell patients, but non-clear cell patients as well, in the context of contemporary IO-based regimens. So a very important study that we should all get behind. And adjuvant therapy, this is coming up all the time. I've gotten probably a dozen emails from colleagues in the community around whether or not we should offer adjuvant therapy to non-clear cell subtypes. I couldn't think of a lot of data to really show up here other than the demographics table from the Totalizumab study. And you can see here that there's just a smattering of non-clear cell patients that were incorporated. So really just not enough data to say. In the last 2 minutes here, I'm going to summarize my thoughts on papillary. I'll perhaps just say that we need to get behind prospective randomized trials. I'm still a firm believer in that, like SWOG 2200, which just opened, like Samita, like PaxiPem, which I mentioned as well. And I did want to mention the other diseases as well. I mean, there's more of a paucity of data here. I really do think we can, if we band together, do randomized studies in this setting. This is the paper that we cite over and over again in the context of chromophobe disease. This is Tom Hudson's paper in European Urology that looked at a series of patients with non-clear cell disease receiving Len/Ev. We saw, amongst 9 patients with chromophobe disease, 4 responders. So that response rate of 44% with Len/Ev keeps coming up in conversation, but there's a very small denominator there. This is this great graphic that Andre Fay put together at his ESMO presentation summarizing Laurence's study and others. And it does show Len/Ev as the high watermark, but what this graph lacks is confidence intervals, right? So, I mean, I'm sure that, we'd probably see wide variation with these small numbers here. And, what I would say is that, we really need to do more to push the field forward in chromophobe disease. Unclassified, sort of same issue here, small numbers. I think this is updated with Laurence's data for Len/Pem, which looks terrific. But again, the small numbers across all of these cohorts here. So I think we really need to do more to understand these other more exquisitely rare subtypes of disease. And sarcomatoid disease, I'm not going to mention much here. Brian had alluded to it very nicely in his talk. And it's brought up several times during the sessions here. I think the bottom line here is we need to use immunotherapy. Ziad Bakouni, one of Tony's fellows, put together this fantastic paper that really explores the biology nicely in the context of sarcomatoid and rhabdoid tumors, but also alludes to some of the clinical data there. So a clear signal of benefit with IO. And I'm going to wrap up there. Thanks a lot.
Impressive on time. So keep your questions, and we welcome all of you online, all of you. We have a lot of partners from industry. It would be great. Any questions is accepted. We're not going to tell your boss. And finally, Dr. Rana McKay, one of our dear friends, been involved with KCRS since the genesis of this meeting. She's going to tell us a bit about the future and what's going on in novel drug in early development in renal cell cancer.
Thank you so much, Tony, for the introduction and for letting me speak here today. I felt like a kid in a candy store putting together this talk. It really gave me an opportunity to go through and look at ESMO, ASCO meetings, things that are happening that are in development, what may or may not be the future of RCC. So these are just sort of my thoughts. Here are some disclosures. And, I'm going to try to break down the discussion around the different approaches to target RCC and the different agents that are being tested, looking at direct tumor cell killing, looking at angiogenesis, and then also looking at immunomodulatory pathways, and kind of going through the different targets in each of those spheres that are potentially, may have promise in RCC. And we'll start with the anti-angiogenics and kind of work our way through. Okay, so starting here, I can't help but talk about belzutifan as sort of the next kid on the block that may actually enter into clinical context. We've already heard a lot about the HIF pathway and its importance in RCC, given this Nobel Prize-winning work. So a little bit about belzutifan, the data from LightSpark 001, phase 1 of belzutifan. And we see data from 55 patients that were presented with a respectable objective response rate of 25%. This was a very heavily pretreated patient population. The median number of prior lines of therapy was 3 prior lines of therapy. We can see the kinetics of this disease, of this agent, and how it works. It's a little bit different than what we see with our traditional TKIs, where we see those objective responses pretty early on. That as you look at the swimmer's plot, you can see that many of these patients have responses that are delayed delayed that are after 12 months of therapy. So I think the kinetic profile of this agent is a little bit different. There's a phase 3 trial that is currently ongoing. It's completed accrual, looking at belzutifan in the refractory setting compared to everolimus. I think we're all eagerly awaiting the results of this study. Belzutifan already has an approval for VHL disease, but looking at potentially an approval in a larger subset. So what do we do in kidney cancer? We see that one drug works, there's another drug that works, we try to combine. LightSpark 003 was a phase 2 that was looking at the combination of belzutifan with cabozantinib. This data was also recently updated and presented. We see objective response rate of 57% with this combination. This is data from, so cohort 1 is the top graph. Cohort 1 was for treatment naive patients. Cohort 2 was for previously treated patients. So we're seeing higher response rates in the treatment naive setting, an objective response rate of 31% from cohort 2. So I think it's going to be interesting to see where this is going to play out. These are the phase 3 studies of the combinations. We already heard about the 012 study looking at various triplets in the frontline space, one of which is going to be the combination of len-pem plus belzutifan. So we're going to see how that's going to impact the landscape. And then building off of not to say the Cabo experience, but rather the combining of VEGF TKI with a HIF inhibitor experience, there's the phase 3 study that's currently ongoing of belzutifan plus lenvatinib. So I think the results of these studies are most certainly going to impact the landscape in both frontline and second line. There are other agents that are also targeting the HIF pathway. This is work from the UT Southwestern group with Jim Bergerolis. The RO-HIF2 is a synthetic double-stranded RNA interference trigger that is to degrade and actually designed to silence HIF2 alpha expression. We see early data with a small signal of efficacy here, objective response rate at 8%, disease control response rate at 39%. Not sure what's going to be the path forward for this agent with upcoming studies, but there's different kind of strategies that are at play for actually targeting HIF. There are other HIF2 alpha inhibitors that are out there. Nightinga 2152 is one that's being tested. It's a small molecule inhibitor of HIF2 alpha. There's a phase 1 trial currently ongoing with monotherapy. There's a press release out of the combination of this agent with Tovazanib. So I think there are other agents that are in development that we need to be on the watch for. Can't help but talk about XL092. XL092 targets pathways that are associated with immunosuppression. It's had a very similar profile to cabozantinib with a shorter clinical half-life and pharmacokinetic properties that are suitable for once daily oral dosing. There's actually two studies that are currently ongoing. The schemas for these studies are way too complex to include onto these slides between dose escalation and the multiple cohorts that are actually, enrolling not just in kidney cancer, but really across multiple solid tumors. So the Stellar 001 program is really looking at the combination of looking at monotherapy and also looking at the combination with atezolizumab plus avulimab. Stellar 002 is looking at the combination with nivolumab and nivo-ipi. So it's going to be really exciting to see how this new kid on the block TKI is going to pan out in the future. So now we're going to kind of shift gears and talk about immunomodulators, looking at different agents that are in the clinic and being tested, some of which we heard about yesterday. So first, thinking about targeting the RCC, immune microenvironment, we can think about strategies of, targeting stimulatory and inhibitory immune checkpoints. We can think about, novel cytokine-based therapies, and then we can think about targeting the, immune metabolic pathways. So we'll kind of try to touch on some of these. So Boten, I'm going to totally botch the pronunciation of these names. I'm going to call it Bot and Bal. Okay, so we saw some very interesting data about these agents. Bot is essentially an FC enhanced CTLA4 inhibitor. Bal, no, it's Bal, is a PD-L1 inhibitor. Sorry, I got my my slide there is a little inaccurate. I think what is unique about the botensilimab is that in addition to targeting CTLA4, it actually also increases Treg depletion, increases T cell priming and expression. So I think it's got, you know, a unique profile as a CTLA4 inhibitor. We saw some interesting data in MSS stable colorectal tumors where the objective response rate was 24% with a disease control rate of 73%. And I think, you know, what's unique about this context is that, you know, these are essentially pretty cold tumors where we're seeing activity. So I think watching out for these agents down the road in RCC is going to be interesting. Relatlimab, I think there's been kind of renewed interest in this first-in-class, LAG-3 blocking antibody. We saw the data from the melanoma Relativity 047 trial. This was a phase 2/3 double-blind randomized trial of patients with previously untreated metastatic melanoma. The primary endpoint here was PFS by independent review that demonstrated a clear improvement with relatlimab plus nivolumab compared to nivolumab alone, and actually led to an FDA approval. And really scouring to see where we are with LAG-3 inhibitors in RCC, I made my own schema from Fraction. So I don't know if this is the actual schema, because I know this trial is very complex and includes people that are, you know, treatment naive and treatment pretreated, but this is sort of my rendition from the clinicaltrials.gov website. But nivolumab plus relatlimab is being looked at in the context of that trial. That trial is fully accrued, so hopefully we'll see some data get presented around what is the activity there in the future. All right, then thinking about linrodostat, this is basically an IDO inhibitor. I think the story about IDO inhibitors have been kind of up and down in RCC. We saw the data from ECHO 202 that got presented in patients. This was basically the phase 1/2 that enrolled multiple solid tumors, both melanoma, non-clear cell, RCC. We saw a signal of activity. There was a large phase 3 trial that was ongoing in RCC, randomizing the combination of epacadostat plus pembrolizumab versus standard of care TKI. Ultimately, this program was shut down given the negative phase 3 in melanoma, but there are other novel, IDO inhibitors that are out there also being tested in the context of Fraction. So we don't know, is this going to pan out in RCC? Is this a dud? I think we're going to be interested to see what basically happens with this agent. Other agents that are being tested, this is the Surface 388 agent. This is basically an agent that is targeting IL-7. IL-7 is an immunoregulatory cytokine which upregulates inhibitory immune checkpoint receptors such as PD-L1, TIGIT, downregulates pro-inflammatory cytokines. There's currently a phase 1 first-in-human that's ongoing. We saw some preliminary data from the dose expansion of patients with clear cell RCC. 100% of patients had been pretreated with IO and VEGF. We saw one confirmed response, but I think more to come about this agent to see what is the role of targeting IL-27. And then we heard about this Savolitanib yesterday. I'm sorry, guys, I'm totally botching all of these names. And the role of the adenosine pathway and its role in basically blocking T cell activation and promoting myeloid suppression. This is the elegant study that Katie presented yesterday. So I think we're going to be really interested to see about the role of this agent in combination with nivolumab. So kudos to Katie and the Vandy team with Brian and everyone. And then we heard a lot about CAR T cells yesterday. Actually, so exciting to hear about the dual targeting CARs of that target CD70 in addition to targeting CA9. This is sort of the ALLO-316 program. This is a CAR designed to target specifically CD70. So this trial is currently enrolling with multiple dose levels. So I think I'm actually excited after yesterday's talk about where we hope to be in the future with regards to CAR Ts in RCC. All right, and then last but not least, we're going to talk about direct cell killing. We're going to talk about antibody drug conjugates, talk about radioligand therapy, Palpable Cyclin. We heard a little bit from Brad Profil yesterday about the Dana-Farber study currently ongoing. So I'll highlight this agent by Daiichi. There's been a lot of excitement around sort of the ADCs that this company is generating. This is DS6000A. It's a cadherin 6 direct ADC that has sort of 3 components. Cadherin 6 is involved in cell-cell adhesion and epithelial mesenchymal transition. Cadherin 6 is overexpressed in RCC, and preclinical work kind of support targeting this pathway in RCC. You know, I think that the key here is, yes, we're targeting this cadherin 6, but the agent here, the payload, is a topoisomerase inhibitor, and how active that is in RCC, I think, is still to be determined. We saw data that were presented at ASCO, I believe, looking at activity of this agent. There's a phase 1 currently happening with cohorts of RCC and ovarian tumors. We saw some early activity. You can see one patient there with RCC that has a partial response. So I think still to be determined what is going to be the role of antibody drug conjugates that have basically a chemotherapy payload. Is that going to be the right strategy in RCC? Do we need a different payload in RCC? You know, it's still to be determined, but I think exciting to see that ADCs are being developed. And then lutetium-177 girentuximab, basically this is carbonic anhydrase 9 targeting radioligand therapy. Really exciting to see, we know that CA9 is a cell surface glycoprotein that's expressed in over 90% of clear cells, rarely expressed in normal tissue. I think the story here, we always hear that like RCC is a radio-resistant disease, and this is linked to beta-emitting radiation. Is this enough? We've been able to overcome the hurdle of radio-resistance with SBRT, where we're able to deliver higher doses of radiation very safely and overcome that radio-resistant strategy. Can we achieve the same effect with beta emission in this context? So still to be determined. I think it's exciting to see the Starlight 2 trial, which is currently enrolling. This is a trial looking at girentuximab and also in combination with nivolumab. So I think we'll see how things evolve with radioligand therapy. And last but not least is Palbociclib, which is selective inhibitor of CDK4/6. We have heard about sort of the importance of the CDK4/6 pathway specifically, which is involved in cell cycle checkpoint control, dysregulation, which plays a role in RCC, may be a good therapeutic target. We saw the initial data from the Kalin lab regarding HIF-independent synthetic lethality between CDK4/6 inhibitors and VHL loss. And currently, Brad is reading a study of avulimab, axitinib, and palbociclib for patients with treatment-naive advanced clear cell RCC. So I think that the future is very bright. There are a lot of different agents that are being tested. Some are going to be winners. Some may not be winners, but I think we're going to continue to track the field. I think there's a lot of interesting compounds to think about taking into the clinic or combining. So those are my key thoughts. Thank you.
That's an amazing tour de force, Dr. McKay. And I knew that this morning again. We all went for, 50 of us went for the 5K run. We were waiting for you, Brian. Tom and I were struggling because Tom was on the call. I was struggling too. But Rana, before the 5K, did 10K earlier on the treadmill. So when we do 5K, she does 15K. So we're going to accept all your questions. Please, if you have a question in the audience, just make sure to tap the mic so that everybody can hear you. Remember, we have hundreds of people over Zoom. I want to also ask, we have a lot of pharma collaborators, and we consider them all family against the cause of curing kidney cancer. So we're going to start taking some questions from everyone. I'm going to start by one of my former and current mentor, Dr. Atkins. Mike the mic.
I can barely see my slides from the podium. I was like, what the hell?
I was pressing the button and the light was on. Okay. So those were great talks, a great summary of the field. I just have two questions. One for you, Monty, which is, Is sunitinib still an appropriate control arm for papillary renal cancer trials?
Yeah, I mean, you do see a sunitinib control, for instance, in the context of Samida, right? I mean, we didn't show an OS benefit in the context of PapMet. If we did, right, then I would say that, we've really got to sort of shift towards and pivot towards Cabo as a control across these studies. But lacking that, I mean, I think it's not unreasonable. If you look across guidelines, for instance, the PapMet trial hasn't done, a ton to sort of influence NCCN recommendations.
So you feel comfortable putting your patients on a sunitinib control arm in a papillary trial?
I mean, for papillary disease.
Squirms.
Yeah, exactly. No, I mean, I personally would, have a discussion around the merits of the trial, but probably offer Cabo as standard of care in those settings.
Yeah, Mike, at least I can tell you in Sumanta, the population is a MET-driven population, so it's a bit different. Then when, running the study in around 20 plus countries with totally different access to cabozantinib, unlike the US, it's very hard, and still sunitinib is accepted and Cabo is not approved. But, questions well taken. I'm gonna ask this is from the online audience to Dr. Rini.
I have a second question if I can.
And maybe I'll just say, but SWOG 2200 does have that Cabo control arm, so,
nice
just.
Unselected. Okay.
This is a general question to everybody, if I could ask it. What do you give after lenvatinib? Does anything work after lenvatinib? It's a great drug, and given with everolimus, it works well, but is it the last treatment that works for patients with
I'm gonna start, everybody has like 5 seconds. Gonna start by Dr. McKay.
Tovazanib, if I haven't used it yet.
Yeah, but does it work?
Yeah.
Martin?
Cabozantinib can work after lenvatinib, seeing it work.
I think something you haven't given before might work. I don't have much data, do we?
Does anybody have any experience with things working?
Yes.
Yes.
Yeah.
Cabozantinib, okay. So this question is for Brian. Why do a significant proportion of community oncologists still use single agent TKI followed by second line nivolumab? I don't have that data, how many currently are doing that. Are you seeing that in practice with your second opinion?
I mean, I think it's happening in the market data I've seen. It's still happening, I don't know, 10 or 20%. You folks may know the numbers more. I don't know why. I don't think that's the standard of care. And so I think it's just kidney cancer is a rare disease. And if you don't see that many patients and don't keep up with the data, you just develop practice patterns that are hard to change, right? And I think the industry folks know in the room, it's hard to change people's practice patterns, right? It takes years to change it, even though we've all been doing it for a number of years.
Yeah, in my practice, I still have a significant number, well, I don't know how significant, number of patients still on VEGF TKI for 10 plus years. And these patients, when they have progression, if there's one site I'll ablate, I always struggle, should I do nivolumab and follow cabozantinib, or should I do nivo-ipi? Because with Hans data, nivo-ipi post TKI, 42%, response rate. I usually do nivo-ipi. We have questions from the audience here. Okay, Todd?
This is Ken Grossman from Merck, and it's actually a non-drug related question. So for the microbiome enthusiasts on the panel, first, do you have a gram fiber amount you think is the right amount to control with in your microbiome trials? And then second, do you have a personal favorite diet that you like to recommend your patients?
Okay, so the first part of your question, the answer is no, we don't have yet that. A lot of teams are working on the fiber amount, and that is something that may come out in the future. With regard to the diet, I think we just need to have prospective assessment. The challenge with diet is that it is very hard to randomize the diet, because either the patient is a strong believer and will do it anyway, or the patient is not willing to take part and ultimately will not respect the diet. So for our intervention study, it's a 3 months only diet. That's so challenging to randomize diets.
This is a great question. And the diet depends what time of the day you are in what country. So being at ESMO in Paris, I had a terrine every day. So you can imagine my diet. We have a question from Dr. Tanir. We're gonna take it here, Nizar.
Thank you, Tony. A great session again. Question to Dr. Powles. Tom, you did a really very nice summary of the adjuvant trials, as always with clarity. I'm going to put you on the spot. At ESMO, in a bladder session in the evening, you said you would not recommend adjuvant nivolumab in bladder cancer patients because you're going to treat 50% more of the patients don't need to be treated, and there is no OS survival. You haven't seen it yet. For patients with RCC who would qualify for, 564, would you put aside the 3 negative studies that just been presented, you summarized? Would you recommend adjuvant pembrolizumab with no OS? Now, obviously, this is different than bladder, where we give neoadjuvant chemotherapy to many of our patients. You mentioned there's a trend towards OS.
Yeah.
But in the absence of, OS.
So the answer is that because in the nivolumab trial, we have no survival data, number one, and because we have a negative atezolizumab study without a survival signal, I think my position there is quite straightforward. Until we see a survival signal of some description trending in the right direction, and I suspect, the EMA has made a decision in bladder cancer of Pd1 positives, label there, the FDA, all comers. There's clearly a lot of confusion in bladder cancer about where we are with those data sets. In kidney cancer, it's more straightforward. The pembrolizumab trial has a clear PFS advantage, and currently the hazard ratio for survival is 0.53, trending in the correct direction. We've seen that signal, and for me, that's enough to say to my patients, yes, we have PFS, and we have OS trending in the right direction. And that's the pivot. As soon as we see that nivolumab survival signal, we will make a clear decision. The ESMO guidelines group is a group of 12 of us in the different cancer types, and that's the position that we've come to as well. So it's not just my position, that's the ESMO guidelines position. We need to see these survival signals in these studies before we can give recommendations. The second we get that nivolumab survival signal, as soon as we can see a hazard ratio with the curves going apart, the guidelines group, I'm sure, will change its mind.
I would add something in bladder that we do not have in renal cell. The data generated by Tom and the team, Joachim Belmont and other, with the ctDNA is extremely appealing, which make me, want to hold on adjuvant therapy. That doesn't and won't in the current time, exist in renal cells. So this is a bit different. Question from Gordon, Dr. Gordon Freeman. Sorry, Gordon, I saw only Gordon. Suit.
And the gut microbiome is occupied. Is there a way to get new microorganisms accepted and incorporated better?
Thank you. So it's likely that by oral intake, you're to some extent able to adjust. However, as we mentioned, it's a dynamic change over time. And so therefore, the question is how long should the patient be exposed, and how any other intervention, we mentioned diet, but we can mention antibiotics, may actually, once again, change the pattern of the composition.
Okay, this is great. Before going here and online, Dr. Brugarolas has been standing for 2 days for this question.
Thank you. I see you are very perceptive. I didn't write this morning.
It's not difficult.
So, I have 2 related questions about papillary tumors. One is, so for some of us, and this is in the clear cell setting, one thing that is attractive about Ipi/Nivo is the durability of benefit. And I didn't hear anything about Ipi/Nivo in the context of papillary tumors, and that's something that I think would be of interest to discuss. And then related to this is I would be interested in what Payal and Sabina can tell us about papillary tumors, because as I understand, the type 2 and type 1 papillary tumors were evolving away from that classification, and it's a lot more complex.
Yeah, I could take a stab at that. In Checkmate 920, I'll tell you that I highlighted that response rate of 27%. Across the cohort, though, again, amongst a multitude of different histologies, I didn't really observe a lot of durability of response with Nivo/Ipi. So, I'll say that, that wasn't really sort of a strong push to offer Nivo/Ipi in this context. I think that the more compelling data certainly comes from combination therapy with TKI in that setting.
There is a study, Jim, of nivo-ipi versus sunitinib. I don't remember if it's papillary or non-clear cell SUNY forecast that I believe finished accrual will be very important for the field. Australia.
All non-clear cell.
All non-clear cell. Hopefully papillary will be the one. Very important to the field. Okay, we're gonna take online question before going here to Naomi and Lisa. You can take as much question. This is because dear to my heart, Phil Abosh here from Philadelphia, from Fox Chase, one of the physician scientists, urologists. Wish Phil was here. Question for Monty. Does anyone know what happens to the tumor microenvironment when you give MET inhibition with savolitinib? How the immune infiltrate looks like, especially if you combine with IO?
Maybe you or Tom would probably be better to answer that with your experience with the combo.
Yeah, so folks have not. So one of the things we're gonna do with Durva, with some of the biopsy at baseline and some of the work we're doing in single cell to look exactly at this. Now we know from preclinical work, not in renal cell context, that MET itself has abates the immune infiltrate and the immunity in general, and that's why MET inhibitor and other members, of that class and that pathway can reinvigorate the immune response. So I wouldn't be surprised here, and I think this is an experiment better to do than cabozantinib, which has also a VEGF among others, and that's a pure MET inhibitor. I don't know Tom here, but the experiment hopefully will happen even if we have a couple of patients versus sunitinib.
So I agree with you. We need to look at it. We need to have a look.
Dr. Haas have been waiting, put everybody ahead of her. Naomi, please.
So this is for Laurence and maybe Monty. So my patients, a lot of them when they've been on VEGF-TKI for a long time are starving to death. They lose their taste. Nobody seems to care about the taste bud question. Do you think the microbiome could address the dysesthesia, that's the biggest complaint, like everything else you can fix. Patients all say, I just want to enjoy food. I just want to be able to appreciate food again.
So I think both of us can try to answer that. The short answer is we're not there yet. My feeling is that although we're to some extent able to adjust with oral intake, we're not restoring that side effect. Is that something that you...
Yeah, exactly. I have nothing to really add there. What's interesting is there is some thought that you can, modulate toxicities associated with, some of the treatments we're using as it pertains to GI toxicity. There's actually a nice paper from an Italian group where they did FMT actually in a randomized study, in fact, and 20 patients receiving targeted therapies for kidney cancer. They found that FMT was able to mitigate, diarrhea substantially. So I didn't see any impact on efficacy in that context, but I am confident that we're going to see some toxicity modulation. I don't know if it's going to be positive or negative when we adjust the microbiome.
And maybe GI, maybe other things, but so far all the evidence at least is for GI toxicity among others. Dr. Hansky, you had a question, I believe.
Thank you, Tony. I want to ask about non-clear cell and specifically chromophobe. As we look forward to having clinical trials that are focused on just one type of non-clear cell, will we be able to do that with the existing clinical trial structures that we have right now, or do new methods to recruit and enroll patients need to be thought about?
Tony whispered in my ear that he wants to take that question.
Yeah, so one of the reasons, many reasons to work with Dr. Hansky is she is one of the, if not the world expert on chromophobe RCC. Her R01 scored a perfect 10 on chromophobe RC, despite telling her it's really crazy to submit on chromophobe. So one of the things, Lisa, we worked on, and you're part of this, is immunotherapy. I think Jim asked a very, very important question here. I think if we have even a subset of patients that respond to immunotherapy, in papillary and other, we should use it. May not be the case in renal cell cancer. We've seen the dismal responses from Andre Fay slides, and we're gonna see work from our group with many, Eli Van Allen, Srini Viswanathan, David Braun, the Dr. Labaki, gonna present how the tumor microenvironment is so cold that you think you're in Antarctica. So stay tuned for something. I don't know, maybe question back to you why the responses to mTOR inhibitor. I think among all renal cell cancer, this is the only one where mTOR inhibitor, the data of Tom Hudson with lenvatinib, I don't think that's lenva only. You know, it has to be the mTOR inhibitor, and that's because of, you know, mTOR upregulation, TOR mutation, not really. Clear cell has that also, so must be something like that.
I think Tony, to chime in as well, I think Lisa had a comment about, do we need to approach our path for clinical trial design and non-clear cell RCC differently? And I do think we need to. You know, I want to commend Darren. I know he was in the room yesterday. I don't know where he is now. The Herculean effort of launching Tiger and utilizing the international infrastructure to do a trial like that in a very niche population that needed to get done. How can we, as a RCC community, launch a non-clear cell platform trial that utilizes the infrastructure of the NCTN and also the EORTC? There is no way that any one institution or any one group can launch a trial just in chromophobe. But I think if we all come together, you know, targeting translocation, like targeting, I mean, the WHO list, every single update is just like blowing up and expanding. So can we actually launch an international platform trial for us to test therapeutic strategies that are favorable to lead into larger studies? I think we as a community need to do that.
Yeah, I think we all need to be excited about the strategy too. You know, one of the reasons I think that this AXI plus minus Nivo for translocation RCC is sort of languishing in the cooperative groups is that nobody kind of looks at that trial and says, gosh, there's a lot of good biological rationale here, you know? On the other hand, you know, for instance, I'd be curious to know what you think about, you know, the data for Lenev and the biological implications of that regimen. But, you know, if we all sort of band together, I think that we can do a prospective study within the cooperative groups. Sort of a single arm trial, I think, would be sufficient, you know, set a bar for response rate in that context and see if we can really sort of make that the standard of care. But, you know, that's kind of what we're doing in the clinics right now, more or less.
There's a lot of little, I mean, I think actually the Children's Oncology Group has a translocation trial that I think has struggled with
That's the
accrual.
one, yeah, AXI-Nivo.
That's so, and then there's, you know, RAM, I think's got a trial for HLRCC. So I think banding together about it, platform infrastructure for us to be able to orchestrate these trials.
And one of the problems with these is the complete lack of innovation. You know, they come after, then you have all these trials, what Laurence reported, et cetera, and others, that, you know, VEGF-IO doesn't give you much. So why would I want to establish a standard now with, let's say, AXI, with VEGF-IO and translocation RC? We totally have a new target. We're lucky to work here with, I don't know, Rini, if you want to get, I like to put you on the spot because you don't like that. Before giving the mic to Gennady, when I talk about translocation RCC. So Rini was in my clinic many years ago, came from George Daly, the Harvard Medical School Dean lab. And one of the things that interested in is translocation in general, forget about renal cell cancer, in a human cancer driving oncogenesis, so lured them into translocation RCC. And your work with Ziad and Srini, finding that this disease is only driven by translocation.
Kind of applying things that were based on the biology of clear cell to non-clear cell that wasn't necessarily going to have strong biologic rationale. So if you have like a tumor type that's driven by VHL loss and hypoxia, and then you're just using the drugs that are approved there for non-clear cell, we really need to think about what's the underlying biology of some of these other histologies like chromophobe and translocation, which is a long game, and then really define a standard of care that's based on the molecular biology of those subtypes.
Good. Yeah. I'm just going to throw in there too. I think it's such an important, you know, topic and question as it pertains to chromophobe. You know, I do think the cooperative groups are probably the best place to do these trials, but I bet if we get creative, we could think of constructs that we can do this in association with our pharma partners. What, you know, for instance, I don't think there's going to be a lot of enthusiasm from a company perspective to push Lenev and chromophobe, right? I mean, kind of ship has sailed, right? But what there might be a penchant for is looking at, for instance, this new formulation of everolimus. Adi Biosciences has this NAB formulation of everolimus that's quite interesting. So maybe that's an inlet for this small company. Maybe they focus on chromophobe, build out a program looking at NAB everolimus plus lenvatinib in that context. So, I do think there's ways to push this forward, both, from a company perspective and within the cooperative groups.
Great. Gennady, been waiting, sorry.
Great session, thank you. A few of us here are mortals, known as urologic oncologists. But we're very loyal because for the past 15 years, we've been accruing very aggressively into every adjuvant trial. And as SUO CTC member, I think we have done tremendous job in supporting trials. And right now we're all hanging on with our nails to KeyNote-564 as the only last hope left, because these are the patients we see. There are 7 of you on the stage. You all know the data. You all know about the progression-free survival and the lack of overall survival and how we have kind of parked the S-track trial and a suit and kind of under the rug now. So question for each of you, if you could, 1 second, but two questions. Number 1, do you use it? And number 2, is there a subpopulation, like for example, the hazard ratio is very low for the M1 completely resected patients? Rana, we'll start with you and you just go around. I'm truly
He's taking over the moderator role. I mean, that's Gennady. Take my next time.
And why am I not on the stage? I'm surprised.
So yes or no, and where won't you use it, Rana?
Or where you will use it?
Yes, I do use it. And yes, it's in select populations. I think those patients that the risk of recurrence is really high, not just at the 50%, but do they have renal vein invasion? They've got grade 4 disease. They're otherwise healthy. I'm not worried about comorbidities. Yes, if there's sarcoma, sorry. Yes.
That's 9 seconds.
Okay.
Martin.
Yes, I do use it. I don't feel as strongly as others about the M1 population. I think we can talk about that for a long time. But at one point I do want to make is, we're always put on the spot, do you give it or do you not? And I think especially in the adjuvant setting, we're approaching this wrong. I think the question is, do you offer it to the patient? I think the patient has a role to play in that decision. If you have a smart patient who can understand the data, you present to them the data, the pros and cons, and the patient is part of that discussion. So,
I agree, Martin.
Okay, great. I love that. Laurence?
Yeah, I'm going to save you some time. The answer is yes, the same way.
I use it. I follow KeyNote-564. One thing, in intermediate, the hazard ratio is 0.68.
I agree. Nothing else to add in terms of subsets.
Brian?
Yes, high clinical risk in sarcomatoid.
High risk in sarcomatoid. Not in all.
I use it in the higher end of clinical risk. So T3s, T4s, high grade, and sarcomatoid.
And you do understand, you give it all in the absence of overall survival data so far. Not to say I go against the 7, but.
It's not absent. It's there. We have overall, it's not that there's no data that's been presented. There's data that's presented as immature, 30% of events. There's a trend. So it's
30% of event, you need a hazard ratio. I don't know the point. Like, what are you gonna tell this patient when they die 3 years later? I'm sorry, the OS came because the event came now. They're gonna come. What if there is an OS? Not there is no OS. So I turn the question like that. Well, thank you.
Just making that point. But anyway, the reason I asked to make a comment is love this discussion with regards to non-clear cell. In this day and age, when we have such a shortage of study coordinators and staff, opening these kind of studies is becoming even more difficult. It already was very, very hard. So, just running it in the cooperative group or running it, in whatever forum is not going to be the answer. I think for companies, this is an orphan indication that they can actually establish a path to an FDA approval. But I think we need some support, as in from a regulatory standpoint. Maybe the patient lobby to a study that will approve 0 patients potentially over 5 years that we haven't opened, but we open it on a case-by-case basis. I mean, maybe there could be a template for that. We just need to think differently for these particular studies, where, we're adopting the same thing that we do for cancer.
Thank you very much. I have to disagree on S-track, 5 years follow-up, OS, hazard ratio 1 with decreased quality of life. I'm gonna take one question. I'm gonna ask for 5 minutes extra from your desk. Dr. Ornstein, a dear friend from Cleveland, asking very good question that Dr. Mesa, your mentee, answered yesterday. If there are ongoing effort to look at the blood microbiome, nobody wanna deal with, you know what, metabolite and compare to stool gut. And yes, Dr. Zidvogel is one of the people leading the field to look at the blood. I don't know how, but hopefully, but that's something that is happening. Dr. Hammers.
Just one last comment on OS as the deciding holy grail, if you should do adjuvant therapy in that space or not. The truth is this trial is not perfectly designed to look at OS, simply because it does not guarantee access to immunotherapy to all patients in the placebo arm. So because this trial was done internationally, there will be a certain percentage of patients who never will get immunotherapy. That was differently done in the melanoma trial. Melanoma trial, the access to immunotherapy was guaranteed. And interestingly, in this trial, there's no OS benefit in a disease that's arguably the most sensitive to immunotherapy. Now, melanoma is a different case because the recurrence, I think, is much more fulminant than what we're experiencing in kidney cancer. But I do think we need to be careful that even if we see this little sliver of OS benefit down the road, that we need to look carefully at the data sets that was driven by patients who never had access to immunotherapy.
Tony, can I take that quickly? So I agree with that. And I think we need to look at the mature data as it comes through. I guess one of the questions I wanted to ask Brian earlier on was when we looked at patients receiving VEGF targeted therapy as first line, do all patients need to have frontline immune therapy in the good risk population? The hazard ratios for sunitinib in the good risk population to 1.0. So I guess we'll look at the data, but it's not clear that all patients need upfront immune therapy when they relapse. One of the questions which we didn't ask, which I want to ask you, is what are you doing in that good risk population? I can tell you in the European guidelines group, we're becoming quite confused because we came in and we were all guns blazing saying yes, 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 but every trial that comes out now, the survival in that group seems to be closer to 1. And in fact, Hans and I were having a bit of a debate about this earlier on, and he was trying to convince me that Ipi-Nivo had the best data in the maturity. So what is going on in that?
I think it speaks to the biologic diversity of favorable risk, right? And we're defining it clinically. We need to define it biologically. I give IO TKI because I don't think single agent TKI cures any patients, right? So, and that's part of the reason why we give Ipi-Nivo, right? It's that tail of the curve, it's that cure fraction. I think the same applies here. So single agent TKI, although it can control disease, is not curing any single patient. You agree? So if I'm a patient with favorable risk, why do I want that therapy? I want a curative therapy. I'm going to mimic Dave McDermott from last week. Think more like a surgeon. You want to think about curing patients.
Although I would argue Dr. Albiges 12 years ago published one of the first reports of CR and long-term remission in JCO when you were a fellow with us, looking at CR and long-term. We have these, but you have to continue that.
It was 0.
French anecdote.
It was European anecdote, 0.7% of patients. Exactly. That's not the 10%, 12% we have now.
But I do think there are additional endpoints that are relevant for these patients who are alive longer, just based on their disease. So if you look at the disease-free survival data that was published recently for Ipi-Nivo, where the favorable risk patients don't look so good in comparison to sunitinib by traditional endpoints, the data does look very compelling, specifically in that group for treatment-free survival and treatment-free survival without toxicity.
I think also we have to be careful. When the VEGF-IO data, Pembrolizumab, Pembrolizumab, Cabo-Nivo, have the same follow-up as the 50 and 60 months of Nivo-Ipi, how would that hazard ratio be? Imagine, because from your 0.53 now it's 0.72. Imagine it become non-significant. I'm not gonna say that doesn't mean there is no OS benefit, but you're gonna have the Nivo-Ipi data with a hazard ratio of 0.6 now with 60 months follow-up. What's that gonna do to TKI-based regimen frontline?
Well, it won't become non-significant because it's already significant, right? So there's no formal statistical testing.
Well,
it can't become non-significant.
Correct, but when someone look at the data,
I think they're all settling out at 0.7. I don't see much change with further follow-up, because most of the events have happened. We'll see, I
Let's see.
guess, but I don't think so.
Because there's a huge difference, as you know, in the median follow-up between VEGF-IO and the Nivo-Ipi now. We have 29 seconds. Lorna is not gonna kill me, so I'm gonna take one more question, Dr. Pal, please.
Feeling very lucky to take the last question. So it's so exciting to see the clinical changes for the treatment. So my question is, when you have such complex combination, especially use the triplicates, does the sequence of the treatment matter? Like how the clinician decide how you're going to treat with these 3 drugs or even 4 drugs, and whether the continuous treatment or intermittent treatment going to make a difference?
Let's see who we're gonna give. Who do we like all to torture the most? Tom. So or Martin. Martin.
So I do think adaptive designs are more important as these treatments get more complex, right? So if you give a triplet or one day a quadruplet upfront, it's not only who do you want to give it to, but also what do you do down the line. I think that's a principal mistake that was made early on with combinations, that they're being given open-ended, right? So a lot of the nivolumab-based regimens were open-ended. Now we're all scratching our heads and saying, well, when should we stop? So I think as we design these studies, especially if they're multi-drug, more toxic, some thought should go into how long do you actually have to give 3, 2, 1. We could write these trials. We could write a trial where you induce with 3 for a month, and you go down to 2 for another 3 months, and so forth. And you could even randomize different approaches that way. I think that would be practical. Looking at Cosmic, I think.
I want a counterpart because I was told I need to cut. I want a counterpart. It's good we talk about that and say this, but I'm a guy that it's all about doing it. The trials in renal cell and GU that is limiting patient after they respond and randomizing, none of them are accruing well. All of them gonna close. So reality, we wanna stop, but actually none of the doctor or patient wanna stop. And that's what's happening with the study we have in bladder cancer with Dr. Jawed, 1,000 patient study, we haven't accrued a patient yet. So that's, it's easier said than done. And second, couldn't be prouder of the pedigree trial led by Tian Zhang here, which is still relevant. It's really near impossible for a trial across, cultures and changes of nations and trials and all that to still relevant. Nivo-Ipi, response adapted when you introduce cabozantinib. We have 70% patient accrued, maybe over 1,000. So please support it, all of you. Thank you. I'm done.